Hello, ladies and gentlemen. Efruzhu Oncotherapy, Dosage, Theoryem, and Lawsadvocates, or another name, same name, Efruzhu antineoplastic therapy, dosage regimens, Theoryem and Lawsadvocates, new session. Mechanism of drug resistance. Mechanism of drug resistance. Clinical drug resistance may occur by a variety of mechanisms. Resistance to a single drug may occur by several different mechanisms, and a single mechanism may result in the resistance to multiply structurally distinct compounds. Most mechanisms of drug resistance have been defined in experimental systems. There is limited information about the role of specific mechanisms of resistance in clinical treatment failures. The general cellular mechanisms of drug resistance include decreased drug accumulation, altered drug metabolism, altered drug targets, and increased repair of drug targets. These cellular mechanisms of drug resistance may result from mutation, gene amplification, or deletion, or altered transcriptional regulation of the drug target. Some mechanisms of resistance are specific to particular classes of drugs. For example, a common mechanism of resistance to methotrexate is increased expression of its cellular target. Dihydrofolate reductase. Other mechanisms of resistance involve more general regulatory or metabolic pathways and confer resistance to several classes of drugs. For example, mechanisms of resistance involving DNA repair or cell death pathways result in resistance to multiple classes of chemotherapy agents. The classical mechanism of de novo and accurate resistance to multiply drugs is expression of P-glycoprotein, a family of membrane proteins that function as drug efflux pumps. P-glycoprotein associated multiply drug resistance is characterized by cross-resistance to a broad array of natural products, including the anthracyclines, antitumor antibiotics, zinc alkaloids, and epipodophylotoxins. P-glycoprotein expression is associated with a poor outcome in a variety of human malignancies, including leukemia, breast cancer, ovarian cancer, and renal cell carcinoma. Similar phenotypes of resistance to multiple drugs have been associated with expression of other membrane proteins. For example, MRP is a membrane protein involved in energy-dependent transport of glutathione-conjugated compounds. MRP expression results in cross-resistance to a variety of natural products, and this MDR phenotype is similar to that associated with the P-glycoprotein expression. You know, cancer cell existence own inadequate energy and all channels gates energy problems. Similar problem and other new mutational receptors and channels gates, channelopathies, for instance. Mechanism of drug resistance: decrease drug accumulation, decrease drug activation, increase drug inactivation, increase repair of drug-induced damage, alteration in drug target, alteration in normal cell death pathways. Because cancer cell at the same time opposite two people. Mutations, group identity and its dynamics, and all products, and normal DNA and its dynamics that silenced, poor conditional, or completely suppressed, inhibited. Chemotherapy strategies: combination chemotherapy. With few exceptions, the use of multiple drug treatment regimens or combination chemotherapy is more effective than single agent, even in clinical responsive tumors. In addition, initially sensitive tumors may rapidly acquire resistance to a single chemotherapy agent by either outgrowth over resistance, clone, or selection of somatic mutations that confer drug resistance. Combination chemotherapy may overcome both of these resistance phenomena. The principles for the development of new combination chemotherapy regimens include the use of drug with single agent activity, toxicity to allow the use of each drug in full dose, and non-overlapping mechanisms of resistance. These principles are not activity may override other considerations. For example, the CHOP, cyclophosphamide, adriamycin, vincristine, and prednisone regimen for treatment of lymphoma includes agents with overlapping toxicities and common mechanism of resistance. Primary chemotherapy. Several human malignancies are curable by treatment with chemotherapy alone. These include gestational trophoblastic tumors, testicular germ cells tumors, Hodgkin disease, some subtypes of non-Hodgkin lymphoma, acute myeloid and lymphoid leukemias, and hairy cell leukemia. The recognition of the potential curative role of primary chemotherapy is important in many of these diseases. Debulking surgery is unnecessary and may reduce the probability of long-term remission by delaying primary systemic treatment. Multimodality therapy. Multimodality therapy. The management of many solid tumors involves a combination of surgery, radiation therapy, and chemotherapy. In multimodality treatment, chemotherapy may be used to downstage the primary tumor, increase the affection of local radiation therapy, or treat microscopic metastatic disease. The purpose and timing of chemotherapy may vary with the tumor type and stage of disease. Several examples are provided here. Women with high risk node positive and node negative breast cancer and typically treated with breast conserving surgery, adjuvant chemotherapy, and local radiation therapy. In contrast, women with inflammatory breast cancer are routinely treated with chemotherapy followed by local treatment. Neoadjuvant chemotherapy improves the local regional control and disease-free survival rates in women with inflammatory breast cancer, and their outcome is correlated with primary tumor response. Approximately one-half of patients who undergo radical cystectomy for invasive transitional cell carcinoma will develop metastatic disease. Because of high distant failure rate and significant morbidity of radical cystectomy, combined modality treatment with transurethral resection followed by concurrent chemotherapy and radiation therapy has been evaluated as an alternative approach to management of muscle-invasive bladder cancer. Prospective trials of multimodality bladder-sparing therapy for selected patients with invasive bladder cancer have reported excellent long-term disease-free and overall survival rates. Randomized prospective trials will be required to determine the equivalence of bladder-sparing multimodality therapy and radical cystectomy. Most patients with clinical localized esophageal cancer treated with surgery alone will develop local or distant disease recurrence. The addition of radiation and or chemotherapy prior to chirurgical resection has been evaluated as a method for improving local control and distant control rates. Prospective randomized trial of surgery alone versus neoadjuvant chemoradiation followed by surgery suggests that multimodality therapy is superior to surgery alone. Additional randomized trials to evaluate the value of multimodality therapy for patients with clinical localized esophageal cancer are ongoing. Our 9 regimens and dosage application, of course, multimodality, but multimodality generally accepted radiation, chemotherapy, surgery, etc. Our genetic sciences, biochemistry sciences, and various oncological sciences at the same cancer cells synchronize. At the same time, multiple mechanism reorganization that the supported pathological neoplastic transformation to the normal condition that supported our physiological balance, homeostatic balance, that would reach healthiness, supportive condition and position. Principles of combination chemotherapy. Principles of combination chemotherapy, single agent activity in the target disease, different mechanism of action, non-overlapping toxicity to allow for the use of each drug in full dose, non-overlapping mechanism of resistance. Adjuvant chemotherapy. Adjuvant chemotherapy. Adjuvant chemotherapy is administered to patients without clinically detectable disease following local treatment with chirurgical resection and or radiation therapy. By treating microscopic metastatic disease, adjuvant chemotherapy is designed to improve the survival of patients at high risk of disease relapse. The theoretical advantages of adjuvant chemotherapy compared to treatment of clinically apparent metastatic disease are compelling. By treating patients with very small tumor burden, most of the obstacles associated with treatment of solid tumors are mitigated, including the problems of drug delivery to a poorly vascularized tumor, de novo drug resistance, low growth fraction, and tumor heterogeneity. Adjuvant chemotherapy improves the outcome of patients with breast cancer, colorectal cancer, laryngeal cancer, osteosarcoma, and BILLS tumors. Adjuvant chemotherapy has not improved the outcome of many other malignancies associated with high relapse rates. This absence of benefit in these other diseases may reflect the limited activity of current chemotherapy regimens or the absence of adequate randomized clinical trials. In some cases, the major limitation appears to be the absence of adequate trials. For example, cisplatin-based chemotherapy for metastatic bladder cancer is associated with complete and partial response rates that exceeds the chemotherapy response rates for metastatic breast cancer or colorectal cancer, while most randomized trials of adjuvant chemotherapy for high risk bladder cancer have demonstrated to no benefit. These trials were underpowered to detect an improved outcome of magnitude similar to the associated with adjuvant chemotherapy for breast and colorectal cancer. Neoadjuvant chemotherapy. Neoadjuvant chemotherapy, the use of chemotherapy prior to definitive local treatment of the primary tumor is termed neoadjuvant chemotherapy. Neoadjuvant chemotherapy has several potential advantages compared to adjuvant chemotherapy, including early treatment of microscopic metastatic disease, the ability to directly assess tumor response to chemotherapy, and the potential ability to downstage the primary tumor. The disadvantages of neoadjuvant chemotherapy include the loss of the precision associated with initial chirurgical staging, the potential delay in definitive local treatment, and increased operative risk following chemotherapy and radiation therapy. Several solid tumors are effectively treated with neoadjuvant chemotherapy, including osteosarcoma and tract cancers, bladder cancer, laryngeal cancer, lung cancer, esophageal cancer, and inflammatory or locally advanced breast cancer. For example, the primary treatment of most squamous and cloacogenic cancers of the anal canal is chemotherapy combined with radiation therapy. Combined chemoradiation for anal cancer is associated with excellent organ preservation and disease-free survival rates. Abdominoperitoneal resection is recommended when combined chemoradiation therapy does not result in a complete response. High-dose chemotherapy. High-dose chemotherapy. Autologous bone marrow or stem cell transplantation involves the intravenous administration of hematopoietic progenitor cells to reconstitute marrow function. For patients following treatment with high-dose chemotherapy, the hematopoietic progenitor cells can be divided from either the patient bone marrow or peripheral blood prior to treatment. This approach allows for the administration of myelosuppressive drugs in doses that exceed the usual maximum tolerated dose. Since most cytotoxic drugs are administered in doses that correspond to the linear range of the dose response curves, the administration of high-dose chemotherapy followed by stem cells rescued has the potential to improve response rates and survival. The role of high-dose chemotherapy in the treatment of most solid tumors is undefined. High-dose chemotherapy has resulted in the salvage or long-term remissions in selected patients not expected to benefit from standard chemotherapy. Favorable results have been reported in breast cancer, neuroblastoma, and testicular cancer randomized trial and required to evaluate the role of high-dose chemotherapy in the management of these diseases, but short period, not long period. Malignancy is often curable by primary chemotherapy, gestational trophoblastic tumors, germ cells tumors, Hodgkin disease, non-Hodgkin lymphoma, some subtypes, acute myeloid leukemia, acute lymphoid leukemia, hair cell leukemia. Prednisone, corticosteroid class, indication lymphoma, prostate cancer, and others. Renal excretion of metabolites, clearance, and side effects, fluid retention, hyperglycemia, because gluconeogenesis mechanism supported by corticosteroids that production of glucose, so hyperglycemia, muscle weakness, osteoporosis. Tumor cells are more sensitive to cold than normal cells, so a semi-selective destruction occurs. Interferon induces both anti-tumor and potentially immunomodulating effect. Retinoids, all trans-retinoic acid retinoids, topically and systematically can be used both as a preventive measure and at times as a treatment. Retinoids have several effects, including potent anti-proliferative and differentiation inducing effect. Topical isotretinoid can be used to diminish the number of precancers and the development of new lesions, and in combination some chemotherapeutic agents with systemic retinoids to control disease in the patient with numerous lesions. Non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs. Arachidonic acid, a 20-carbon polyunsaturated fatty acid, is the precursor of prostaglandins. The first step in PG synthesis is hydrolysis of phospholipids to produce pre-AA arachidonic acid. The next step is catalyzed by cyclooxygenase, which inserts molecular oxygen to produce prostaglandin G2. An unstable product, prostaglandin G2, is rapidly converted to prostaglandin H2, the common precursor for all other prostanoids. By cyclooxygenase peroxidase activity, cells contain genes encoding at least two isoforms of COX, cyclooxygenase 1 and cyclooxygenase 2. Cyclooxygenase 1 is expressed constitutively in most tissues and appears to be responsible for the production of prostaglandins that mediate normal physiologic functions such as maintaining the integrity of the gastric mucosa and regulation renal blood flow. In contrast, cyclooxygenase 2 is the induced by cytokines, growth factors, oncogenes, and tumor promoters, thereby contributing to the synthesis of prostaglandins in inflamed and neoplastic tissues. Prostaglandins accumulate as a consequence of increased cyclooxygenase 2 expression, which in turn is associated with cancer phenotype. Mechanism by which overexpression of cyclooxygenase 2 contribute to carcinogenesis may involve chronic inflammation, immunosuppression, and angiogenesis, as well as modulation of epithelial proliferation, apoptosis, or invasive properties. Null mutation of the cyclooxygenase 2 gene reduces the number and size of intestinal polyp in an animal model for FAP. Similar inhibition of cyclooxygenase 2 function suppress polyp formation in mice and azoxymetan-induced colon cancer rats. Non-steroidal anti-inflammatory drugs, aspirin, indomethacin, sulindac, prioxicam, suppress cyclooxygenase 2, inhibit colorectal carcinogenesis in animal studies, and reduce the risk of mortality from CRC in epidemiologic studies. Aspirin reduced the risk of developing adenomatous polyps, especially with prolonged use for longer than 5 years. Sulindac causes regression of adenomas in FAP patients. Clinical trials to establish the efficacy of the agents have been initiated, and preliminary results show considerable promise. That's all this program, and other program will be continue. I hope we will be join us together other programs. Thank you very much. Thank you so much. See you soon.